Thank you for tuning in to week 3 of these educational sessions. This week we're going to talk about the NICU. There are a lot of topics to discuss when it comes to the NICU. However, due to the nature of this project, there's simply not enough time to do a deep dive. So today I'm just really going to scratch the surface. And if you have any additional questions, you can consult your doctor, or if you're receiving OT services, they can kind of help answer some of those questions as well. If you haven't tuned into the other sessions, we have already covered postpartum physical health and postpartum mental health. You can find these sessions on our website, which I will have linked at the end of this presentation. If you don't know me, I'm a third-year occupational therapy student finishing up my last semester of OT school. My name is Grace, and I myself am a mom to a 1-year-old. And if you don't know what occupations are, that's okay. A lot of people don't. But occupations are the things that we want and need to do in a day. So a few of my favorite occupations are playing with my daughter, going on walks during sunset, particularly when it's warm out, and binge watching TV shows with my husband. If you're watching this recorded lecture on our YouTube, I would still greatly appreciate you taking this pre-survey. This just helps me understand how effective this session was, and I would greatly appreciate it. These are the topics that I'm going to go over during today's session, and we'll jump right into our first one. So there are a lot of words on this slide, and it can be very intimidating. I don't want to go too in-depth into each one because it can get very overwhelming. So I'm going to cover just a couple that I think are very common in the NICU, and these slides are available on our website, as you may have already seen. And the website that I got these terms from will be linked in our references page as well, so you can feel free to go check that out. One term that I think is important and very, very common in the NICU are APGAR scores. So these are scores that are given to a baby after they're born that look at appearance, so things like skin color, heart rate, reflex irritability, muscle tone, and breathing. These essentially score your baby's health when they're born, and these aren't just for NICU babies. All babies receive this, but more often than not, NICU babies are receiving lower end APGAR scores because they're born early and they may need supplemental oxygen or other things to promote health for them. And then another one that I think is pretty common in the NICU is apnea. So that's when there's a pause in breathing that lasts longer than 15 seconds. So you may see this in your baby's chart. And if you're concerned about this, talk to your doctor. They may have more insight on whether or not to them it's concerning. And then I just wanted to review 4 medical terms that I think can be helpful when trying to decipher different terminology that might be in your or your baby's chart. So the first is tachy. Tachy is a prefix and it means fast. So when you combine that with another word, let's say, for example, cardia. Cardia means heart. Tachy and cardia together would mean fast heart rate. Brady is also a prefix, but it means the opposite, it means slow. So if we replace tachycardia with bradycardia, that would indicate slow heart rate. Hypo is a prefix that means low. So an example where you might see this would be hypoxia, which would mean low oxygen levels. And then hyper is the opposite, and it means high. An example where you might see this would be hyperglycemia, which would indicate a high blood sugar. Again, with this slide, I don't want to go too in-depth into the terms up top. It can be very overwhelming. Vital signs are pretty important in the NICU. They are things like heart rate, respiratory rate, temperature, blood pressure, and pain level. I'm going to go over here in a couple slides reading the monitors that your baby might be hooked up to, and those are generally where those vital signs are present. But down at the bottom here, we have a few more medical terminology terms that I want to go through. So like I talked about, cardio or cardia indicates the heart. So like I said, tachycardia, tachy and cardia put together is fast heart rate. Gastro means stomach, nephro is kidney, encephalo is brain, hepato is liver, and pulmono is lungs. The medical jargon that's used in the NICU can be very intimidating, and this is just a very small sample of some of the words you might come across. So if you see something in your baby's chart that you don't understand, don't be afraid to ask your nurse or another medical professional that's on the floor. They can help describe that to you and indicate maybe what's going on with your baby within that term. Another aspect of the NICU that can be very intimidating is all the different equipment that your baby might be using. So I listed just a few here. There are a ton, and some of these may not be prevalent for your situation, but they are pretty common in the NICU setting. So I want to go over just a couple of them. The first being a nasal cannula. This one is very common, not only in the NICU, but other parts of the hospital. So this is like a little plastic tube that goes into your baby's nostrils, and it just provides supplemental oxygen to your baby. A lot of times it's plugged into the wall, and that's where that oxygen flow is coming from. And then a pulse ox. This is one that's very common, and it is a small device that's generally wrapped around your baby's foot or hand to monitor the amount of oxygen that they have in their blood, and a lot of them also monitor your baby's heart rate as well. Some babies might be too little to get a good reading on their foot or hand, so it might be placed somewhere else as well. These slides will be available at the website that I'll have linked at the end so that you can review some of these other terms that I didn't go over. Okay, so this is where we're going to talk about the monitors that you typically see in a NICU that your baby might be hooked up to. So I put a picture of what a typical monitor might look like here on the right, but every hospital can be different. So if your monitor at your hospital varies, feel free to ask your doctor what each number means or your nurse. They can help explain that and tell you kind of what general parameters they want your baby in. So starting with that green number at the top, this is heart rate. And so a typical heart rate for a NICU baby is around 100 to 200 beats per minute. That white number underneath the green one is the respiratory rate. And with these, if you look just above the big numbers for each one, there's these little, like the top one says HR, heart rate, and the white one says RR, which would be respiratory rate. So that can also help give you an indication of what each one is reading. That respiratory rate one is how many breaths per minute your baby is breathing, and what is typically considered a normal range in the NICU would be 30 to 60 breaths per minute. The blue one just underneath that white one is called the SpO2. So this essentially monitors the percent of oxygen that is in your baby's blood. So on this specific monitor, that would be 97%, which is good. Generally, doctors want babies to be above 90%, although living at a higher elevation can change what doctors consider to be a typical or kind of like that cutoff of where they want a baby. And so talk to your doctor if you're living at a higher elevation and what they may want your baby to be at. And then in the bottom left corner, there's a pink fraction. That is going to be your baby's blood pressure. What might be considered normal for a NICU baby can vary depending on how early your baby was born and any other medical complexities your baby may have. So this is one you definitely want to talk to your doctor to see what a typical reading is and where they want your baby to be. And like I said, with any of these numbers, anything can change what may consider it to be normal. So if your baby is born at 24 weeks, that might be different than a baby who is born at 35 weeks. So talk to your doctor and see where your baby should be at. They are monitoring these, and the nurses keep an eye on them as well. But if anything happens that is concerning to you, you can talk to your doctor or your nurse. On to our next topic is feeding. Feeding is one of the big focuses that an OT will help develop with a NICU baby. Eating and feeding is far more difficult than most people think it is and that it appears on the surface. Many things need to come together appropriately in order to have a successful and safe feed. While in utero, infants will begin to practice their feeding skills by swallowing amniotic fluid. If a baby is born early, this could disrupt their ability to practice the skill, and their coordination of their suck, swallow, breathe may be delayed. This can lead to unsafe feeding and potential aspiration. So that's when like a foreign liquid or foreign object enters your lungs. Additionally, babies born premature or who become sick and require NICU stays oftentimes have additional medical complexities that may impact their feeding skills. So this may be things like difficulty breathing, like they're breathing really, really fast. That could increase risk of aspiration, or low muscle tone. So their muscles in their face get really weak, and so they can't appropriately feed on the breast or the bottle. Some feeds may need to be delivered via a tube or an IV if your baby is not quite ready for breast or bottle feeds. And so IV feeds are essentially where nutrients and hydration are delivered straight into an infant's veins. It doesn't go through their digestive tract at all. And this one is kind of a more urgent need. There are also tubes that can go through a baby's nose, like you can see pictured on this baby here. Some go through the mouth, and there are even some that have to be surgically inserted through the baby's belly. And so your baby may require one of these feeds, and it can be very scary, very intimidating. So get all the information you feel you need from your doctor and your nurse. And with tube feeds, it's okay that it might be scary, but just lean on the people that you have with you, lean on your doctors, on your providers. They can help guide you through kind of the process of what getting that tube eventually out looks like for your baby. If your baby is not yet ready to transition to breast or bottle feeds, so they may be on tube feeds, there are some activities that you can do to help kind of guide them towards that transition. The first would be keeping a scent cloth that smells like mom in the baby's bed. This can provide comfort to a baby and create a calming environment, which can promote safe and positive scenarios with eating. Performing skin to skin with your baby can also bring comfort and is helpful to promote bonding. It's often suggested that if a baby is receiving tube feeds, that parents are still performing skin to skin during those feeds. Like I said, it can create a positive experience during feeding, and this is really essential for babies' feeding skills onward. If babies develop negative experiences with feeding early on, it can actually impact their feeding skills long term, well into their childhood. With your doctor approval, you can give baby small drops of breast milk on your clean finger or on the end of a pacifier. Like I said, it's very important to get doctor approval with this. Your baby's digestive tract may not be ready, and so consult your doctor before you perform this. It is very common that a baby is not ready to transition to breast or bottle feeds until 32 to 34 weeks. This is because the coordination of their suck, swallow, breathe has not started to kick in yet. And so if you're trying to do a bottle before they're ready, it could cause aspiration and create negative experiences around feeding. And many other factors play into a baby's readiness, including medical stability. So this will be kind of a co-decision that you make with your doctor on knowing when your baby is going to be ready to transition to breast or bottle. So as your baby grows, it's likely that an OT will come in. Sometimes it's an SLP as well, to address the transition to bottle and breastfeeds. First and foremost, like I said, your doctor is going to provide insight on when your baby will be approved to start breast and bottle feeds based on their medical status. So they look for things like active bowel sounds to make sure that your baby's digestive tract is working. they look that your baby has passed meconium stools. Meconium is that thick, dark stool that a baby passes the first few days of life, and it can indicate that a digestive system is mature and functioning normally. Doctors will also look for signs of abdominal distension or infection. This can kind of halt their desire to start bottle or breastfeeding. But once your baby kind of hits that 32 to 34 weeks gestation and your doctor approves it, you can kind of start helping them develop some of that suck swallow breathing. Babies will begin to show signs of sucking on their hands or sucking on a pacifier, and these are all good signs that your baby's headed towards those breast or bottle feeds. A few things that you can do to promote successful transition to those milk feeds. The first is a side lying position on the left side. So this emulates breastfeeding and can get a baby comfortable with this positioning before transitioning to the breast. Can be very beneficial so it doesn't feel like something completely new. In this position, you generally want to be able to also make sure you have baby's head tilted upwards. You don't want them completely flat. Tip them up just a bit. The reason why we look at the distinction of the left side when side laying while feeding is that the shape of the stomach helps reduce reflux in this position, and so it can be really beneficial for especially NICU babies where you want to promote those positive experiences with feeding. Additionally, you can help baby by pacing their feeds. So for some babies, it actually might be more beneficial to simply just tip the bottle back to slow the flow of the milk. And for other babies, it might be more beneficial to take the bottle out altogether. If your baby has a hard time latching, you probably want to avoid taking the bottle out altogether. You don't want your baby using too much energy on trying to latch because they use a lot of energy having to feed. And so you know your baby best, so help pace as much as you can. And you can also use different nipple flows to help pace as well. Many bottles have their nipples labeled by the flow, so things like preemie, 1s, 2s. The thing with bottles is every brand's flow can actually be different, even if they're labeled the same number. So a Dr. Brown's preemie might actually be different than a Phillips Advent preemie. And so you kind of have to experiment what bottle works best for you and your baby. And it's often recommended that you use whatever bottles you plan to use at home while in the NICU. A lot of times you're provided these little hospital grade nipple tops, which is more than likely what this baby in this picture is eating with here. And while those can be helpful, you want to try to your best to use the ones that you're going to use at home so that baby can get used to those early. And while you have the support from an OT or speech therapist. While feeding your baby, it can be beneficial to swaddle them, so bringing their arms and their legs close to their body, because if a baby's arms and legs are out, moving around, their brain is now trying to focus on the movement of their limbs and feeding at the same time. Bringing those limbs together can allow the brain to focus primarily on the mechanics of feeding, like latching and coordination, versus movement of the body. You can also work on non-nutritive sucking to support the transition to the breast or bottle. So non-nutritive sucking can be done through the use of a pacifier, and it helps babies build strength and coordination in their sucking patterns. And finally, a new focus to feeding that's really starting to emerge and has shown to be effective in helping introduce bottle or breastfeeding is infant-driven feeds. This means following your infant's cues to indicate when they might be ready to eat. And for some babies, this might be before those 2 hours are up. And if that's the case, then try to feed your baby and see how it goes. Following your infant's cues have been proven to lead to success during the transition to breast or bottle feeds, rather than solely following time-based and volume techniques. So some cues that your infant may be giving you that indicate they're hungry and they're ready to eat include putting their hands in their mouth, smacking or licking their lips, clenching their hands into tight fists, moving their head around. So this is called the rooting reflex. They're essentially looking for the breast to eat, and crying. But there are also other cues, which are called stress cues, that you want to look out for when feeding your baby. If you notice a stress cue during your baby's feed, it means your baby is not tolerating the environment around them or the feed that you're giving them. And so if you experience stress cues, you want to stop that feed so that you're not creating that negative experience around feeding with your baby. Some of these cues may include grimacing, their arms or their legs waving or kicking kind of sporadically. A lot of babies will splay their fingers like wide and open, almost like a stop sign. And then gulping, gagging, or squeaking noises, or if baby is actively moving away from the breast or the bottle. Like I said, if your baby exhibits these during a feed, it's important you stop, comfort your baby, and just check to ensure that they're recovering from these cues. You can do this by looking at your baby's skin color, their breathing, and their level of alertness. If a baby is coming off of that feed and they are not responding or they're limp, that is definitely a cause for reaching out to your doctor, and in some cases, even a visit to the emergency department. So, you know your baby best, and it's also oftentimes in the NICU, the focus is on quantity of feeds rather than quality. But quality is very important because feeding success comes with a feeding that's enjoyable, stress-free, and infant-led. I want to just briefly cover a little bit about breastfeeding. I'm going to do a series on pediatric feeding here in a few weeks where I'll cover this a bit there as well. If you have any questions regarding breastfeeding your baby, you can consult an occupational therapist or a lactation consultant. Both can kind of play their own role in helping with breastfeeding. If you have a baby in the NICU and you've decided to pump, it's actually recommended that mothers have pictures of their baby or something that smells like their baby with them while they're pumping. This is due to the release of oxytocin. So that's a hormone that helps promote milk production. And that release of oxytocin relies on a contact between a mom and a baby. And so if your baby's in the NICU and you're pumping, say at home, not having that contact with your baby can impact that oxytocin release and then can further decrease how much milk you're making. Generally, when you're going to latch your baby, a common phrase that can be used to guide a latch is chest to chest. So your baby's chest to your chest. You want baby's nose to your nipple. And then you want baby's chin to your breast. So that chin should be pressed flat against your breast. And then you're going to bring baby in with their nose being at your nipple. That's going to allow them to reach up to latch, and it creates this nice wide latch that we're looking for. And then you're going to bring your baby to your breast. You're going to hold baby nice and close and keep holding them there while they're feeding. A few positions that can be useful during breastfeeding are listed here at the bottom. I'm going to go through each one just briefly. The first position is called the cross cradle hold. In this hold, it frees up one of your hands to hold your breast and guide the latch, while the other hand supports baby's entire torso. In this hold, you want to have baby at an angle so that their head is up above their heart, kind of like I talked about with that left side lying with the NICU feeding. You want their head up at an angle. This hold can be beneficial for a mom who's new to breastfeeding because it allows you to have both hands to assist baby to latch, and for fragile infants that you see in the NICU. The next one is a football hold. In this position, baby's feet are pointed towards your back, and a pillow can be used to provide full postural support. This provides full support through a side laying position which can also be helpful for mothers who have motor complications, so where holding baby up can be really difficult, or for moms that have twins so that they can feed both babies at the same time. I also think this position can be helpful for moms who have had a C-section because baby's kind of more off to your side and it takes a little bit of pressure off of your incision. This third position is called side laying. Kind of like we talked about already, that side lying position can be really helpful for a NICU baby. It provides full postural support for not only baby but mom as well. And so this position can be beneficial, again, for moms with C-sections. You're taking off that pressure onto your abdomen, and so that can help reduce pain. And mothers with motor complications, it requires a little less muscle, as it would be like sitting up and holding your baby. With this position, it is important to note that there is a risk of falling asleep. You are lying down with your baby, and so you need to consider that when going to feed your baby, and just be aware that this is a risk for your baby. The fourth hold here is the cradle. This one's pretty traditional. It requires the most work on a mother and an infant's part. You're kind of working against gravity on both ends, and because the way that mom holds baby's head, there's less ability to use both hands to help support a latch. And the final hold is called an Australian hold. So this hold uses gravity to help with baby's body alignment with the mother's breast. This hold is typically used for larger babies or infants with special needs due to the elimination of gravity that requires less strength and endurance to feed. This position can also help slow milk flow naturally because you're kind of taking gravity out of that situation. Development is another area where OTs often play a very big role with NICU babies. Babies who are born before 37 weeks will follow developmental milestones for what we consider to be their corrected age. They'll follow these up until they're about 2 years old. So, to understand and calculate your baby's corrected age, you take your baby's current age in weeks and subtract how many weeks premature they were born. So, for example, if your baby is 4 months old today, that into weeks would be 16. But your baby was born 2 months early or 8 weeks early. So 16, which is what your baby is now, 16 weeks minus the 8 weeks that they were born early would be 8 weeks total, indicating that your baby's corrected age is 2 months old. A therapist would use this calculation to evaluate your child's development to ensure that they're meeting their 2-month-old milestones rather than 4-month-old milestones. And this can be very complicated, very tricky, but essentially you just want to look at when a baby is born premature. While yes, they had this, let's say this baby, for example, had an extra 8 weeks after they were born. Well, that 8 weeks was spent developing how it would have been in utero. And so it doesn't make sense to calculate them on 4-month milestones because 8 of those weeks are essentially equivalent to what they would have been doing in your belly. So we want to look at from the time essentially that they were supposed to be born. And so developmental milestones are typically assessed in categories. This includes physical, cognitive, language, and social emotional development. This chart lists some milestones that can be expected at the 2, 4, 6, 9, and 12-month range. This is not necessarily an all-inclusive list, but we're going to just kind of briefly go through each of these. So at that 2-month-old mark, your baby should calm down when you speak to them. They react to loud noises, so this doesn't mean that they have to startle necessarily at loud noises, but if a loud noise happens, they look towards it. They start making sounds other than crying. Typically, they're not quite cooing just yet. That's generally around 4 months, but they might be kind of, in a way, babbling. Babies will hold their head up, oftentimes very briefly, while they're on their tummy, and then you'll start to notice their little hands are opening more. At 4 months, a baby will start to smile to get your attention. This is when that cooing typically starts, and they'll hold a toy that is put into their hands, and they can push up on their forearms when they're on their tummy. This is not, when I say forearms, I mean that their arms are generally bent at a 90-degree angle, and so they're resting on that forearm. They're not pushing up through their hands quite yet. At 6 months, a baby typically begins their laughing. They recognize familiar people. Blowing raspberries is very common at this age. They'll roll tummy to back. Tummy to back is easier for babies to roll than the other direction because gravity kind of gives them a boost to get over that arm. And this is when babies will start to push onto their hands while they're on their tummy rather than just sitting on their forearms. At 9 months, baby will start to show fear around strangers. They'll respond to their name. This is when true babbling begins, so things like mama, mama, and ba, 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 ba. They will sit without support. And something that was kind of more recently taken away as a developmental milestone is crawling. Crawling is actually a very, very important skill. It helps build strength, it helps develop the sensory system, and so many other things. Crawling is not listed as a developmental milestone in any of these months on the CDC website. That is where I took these from. But I think it's important for parents to know that crawling generally develops between 7 and 10 months. So I think that is one that was taken off that shouldn't have been taken off, and it's an important skill to have and for parents to know when to expect it to develop. At 1 year, your baby will start waving bye-bye. They understand the word no. That doesn't mean they'll listen to the word no, but they're going to understand it. They'll start pulling to stand, so a lot of times they're going to use furniture to do this, or your fingers. Babies will start kind of walking using furniture, so we kind of call this furniture surfing. So they might start taking side steps while holding onto a couch. And their pincer grasp starts to develop. So that's when they start grabbing things between their pointer finger and their thumb. Your baby may reach these milestones a little early or even a little late. I recommend getting a milestone tracker from the time that baby's born so that you can keep track of what milestones baby is achieving and what ones they might be a little behind on. I personally really liked the CDC one just because with each milestone it would have like a not yet, like a yes, and a not sure. But they also had like pictures and videos of each milestone. So if I read one and I was like, I don't know what that means, I could click on the picture or video and it would show me a baby doing that skill so I could know whether or not my kid was doing that. And I also with this one get like a reminder before my baby hit each of these ages to fill it out. And so then I would have kind of a checklist of the ones they were doing, the ones they weren't before I went into my baby's pediatrician. And so I could bring up any concerns from there. There are lots of other milestone trackers as well, so you don't have to choose the CDC one. You find the one that's right for you. A rehab therapist, so occupational therapist, physical therapist, speech therapist, can help your child achieve these milestones and can provide recommendations on how you can continue to promote their developmental growth. So if you have concerns about your baby's development or your doctor shares concerns, definitely look into the different therapy services that might be helpful for you. Promoting development doesn't just start when your baby is 2 months old. It starts from the time they're born, and for NICU babies, it starts from the time they're born, even if that's considered to be early or premature. A baby's age and medical condition can impact their ability to start this developmental process, and it can be intimidating for you as a parent if you have a baby in the NICU doing things like holding your baby and promoting your baby's development because they might be connected to different tubes and wires. But it's important that you start doing this from an early age because this is really what's going to start pushing your baby's development on. So discuss with your doctor your desire to care for your baby on the floor, and if approved, depending on your baby's medical status and age, you can really start taking a more active role, and this is going to help your baby develop and grow a bond with you. So the first with communication, depending on the age that your baby's born, their hearing is often very, very sensitive. So it's important that you communicate gently using a soft, whispering voice. You can talk to your baby, read to them, or sing to them. And baby knows the sound of your voice from when they were in your belly, so it does bring them comfort while being in a high stress environment. Providing touch can help promote development in the NICU. So skin to skin, gentle and consistent touch, or putting your finger in baby's palm can be very calming for your baby. Once your baby gets to around 31 to 33 weeks gestation, with doctor approval, you can start doing a gentle massage on baby's arms, legs, and body. You can sit baby upright and do a gentle rocking back and forth. And you can start doing gentle stretches of your baby's arms and legs. And then last, with visual stimuli, baby's eyesight is very sensitive when they're born, especially when born premature. So you want to make sure you're following any instructions your doctor has given you. At first, you will want to limit visual stimulation. So this is things like bright lights. Those can be really overwhelming for a baby's sensory system. As your baby begins to open their eyes, and once your doctor approves, you can start introducing things like contrast books, making eye contact with your baby while you're talking or singing to them. And all of these are ways that you can really start promoting your baby's development from very early on. So, attachment. I go more into general attachment next week. But attachment is an ongoing process that begins in the first few months and continues to develop over several years. Attachment actually starts when you're pregnant with your baby, but a lot of times you look at what can I do once baby's born to build that attachment. And so that's kind of where we're focused on here, especially with NICU babies who are in a more high stress environment. It's important you begin your bonding journey with your baby early, but like I said already, it can be intimidating to hold your baby. So you want to do the best that you can, but also know that a baby's attachment is not set in stone right away. It's something that builds over the first 3 or so years of their life, and even after that, it can be shifted and changed. So do what you can to bond with your baby while in the NICU, but also when you take your baby home, that's a great time for you to really start building that bond. Holding your baby is a great way to start building that bond with your baby. Being part of their regular care times, so changing their diapers, helping do feeds, giving them baths, are all really important to building that bond, and it helps you learn your baby's cues as to maybe what they're wanting. You can provide hand hugs to promote comfort for your baby. So this involves gently cupping one hand around your baby's torso or their legs and the other near baby's head and providing just very gentle pressure. It is important that you interact with your baby as much as you can to help build your bond with your baby. And providing care in a predictable manner also allows your baby to feel safe. So starting to build routines as much as you can while you're in the NICU, even if it's as simple as bath time, then reading to your baby, feeding your baby, and then bedtime before you, say, leave the NICU for the night. And then finally, this one's kind of just more general, but it's more important than I think a lot of people realize. But when you pick up your baby, try to make sure you're providing support behind their neck, but also through their bottom as well. Sometimes when you're lifting your baby under their armpits and it leaves their bottom dangling, it can actually result in baby not feeling as safe or secure as they would be if you were picking them up with your hand supporting their bottom as well. Most importantly, bonding takes time. It's not an instant process, so it does take a little bit of patience. And especially in a high stress environment, it can definitely impact how you bond with your baby. So if you have questions, consult your doctor or your occupational therapist if you have one. Navigating having a baby in the NICU is not an easy thing, and let alone when you have other children at home. So, a lot of times it often brings up feelings of guilt for parents as they have to split the time between home and the NICU. And for some parents, it's even further if they have two babies in the NICU and a baby at home. Um, a few ways that you can help support your non NICU children include maintaining consistent routines. So, being there for their school drop off or bedtimes can make a big difference. You can involve them in the baby's care, so this means visiting the baby when possible, drawing pictures for baby's room, or having them choose a small stuffed animal to bring to their sibling in the NICU. While it can be hard to leave your baby in the NICU, it is important that you're also prioritizing one-on-one time with your children who aren't in the NICU. This can be as simple as doing lunch with one of them one-on-one, or a quick shopping trip with them one-on-one. And finally, encourage open conversation about how they're feeling with having a sibling in the NICU. It's okay to acknowledge that it can be scary, and their feelings with it are valid. And having a baby in the NICU can cause extreme stress, feelings of guilt, significant fatigue, and emotional instability for caregivers. You are not alone in this, and while it might feel that way, there are people around you that want to provide you that support. But just a few ways that you can continue to take care of yourself while your baby's in the NICU include maintaining your daily routines. So, including eating proper meals, getting sleep, taking showers, reaching out to support resources to see what they can offer you to help you support yourself. So, one that I think can be really helpful are support groups. This is a great place to connect with other people who understand what this experience might be like. And one that I think is maybe more underrated than it should be is taking breaks outside of the hospital. Being confined in those four walls, whether you have a window or not, can take a toll on your mental and your physical health. So, something as small as taking a walk outside can be a huge game changer. It is okay to need help. A lot of people like to use the analogy of putting your oxygen mask on before helping someone else or helping a child. You hear this a lot when you're on an airplane, but it's true. You have to be able to take care of yourself in order to pour into your children and those around you. So, taking care of yourself is just as important as taking care of your baby. Occupational therapy focuses on helping people gain the skills to perform the occupations of their daily life. Like I said earlier, occupations are anything that someone wants or needs to do in a day. So for NICU babies, this might involve things like eating, sleeping, bathing, and interacting or bonding with their parent. Some things that you could expect from an occupational therapist in the NICU setting includes parent education, promoting positive sensory experiences. So, like I said before, this can be done through things like dimming the lights, giving hand hugs, massages, and educating parents on what level of sensory input their infant needs depending on how early they were born. OTs also promote age-appropriate development by interacting with baby in an age-appropriate manner. They can work on feeding, so this can include positioning with feeding, watching for those stress cues with feeding, and beyond the NICU, OTs work on feeding for older children as well. And in this setting, OTs can work to prevent contractures and muscle atrophy through movement techniques. So for babies, especially babies that were born really early, having gravity kind of weigh on them while they're laying in that incubator can cause their muscles to become weak. And so OTs can help provide stretches and movement of the limbs to help keep those muscles moving. Beyond the NICU, occupational therapy will likely play a role in your child's care. When a baby is born before 37 weeks, that's what's considered premature. It's pretty common for hospitals to refer these families to early intervention services. So, early intervention services provide therapy such as speech, occupational therapy, and physical therapy to children from age birth to age 3. Some services and programs even provide it until age 5. Early intervention services typically occur in the child's natural environment, so this can be at home, at daycares, at school, and therapists will collaborate with families to create goals that promote age-appropriate development and life skill acquisition. If your child did not receive a referral to early intervention services, but you're concerned about your baby's development, you can reach out to your local early intervention program. Some of them provide free screening to determine the need for an evaluation. So, in terms of my local city, I'm located in Cheyenne, Wyoming, and so our early intervention services are called Stride, and they will provide a screening to determine whether or not your child needs an evaluation for services. This is the handout that was made to correspond with the lecture material today. This is also on our website, which I'll have linked here in a few slides. This is that post-survey. If you filled out the pre-survey, even if you're watching online, I would greatly appreciate you also fill out the post-survey. Like I said, it's anonymous. It's really just for me to see how effective these sessions were. That bolded text is going to take you to the website that I've referenced several times today. And then if you scan this QR code, it's going to take you to a Google Doc that has a list of local Cheyenne resources that might be beneficial to you. But I also wanted to include just a few NICU-specific resources. So the first one listed here, that postpartum international support. They have a help hotline. They post educational materials, and they have support groups for both mothers and fathers who have babies. That Hand to Hold provides support groups, mentorship programs, podcasts, bereavement support, and counseling support. The NICU Dad provides support resources and a podcast for fathers that have babies in the NICU. And the NICU Helping Hands provides education, support groups, and other programs to NICU parents. Next week, I will be reviewing infant attachment, and I will upload a recorded video of that session as well to our YouTube for you to view later. And if you scan this QR code, it'll take you to that reference sheet where you can find the information on the medical terminology and the NICU equipment and all the things that I talked about today. Thanks so much for listening.